Hello and welcome to the Fujifilm SonoSite webinar discussing practical sports ultrasound with Dr. Tarek Awan. My name is Daniel Shelton, Director of Musculoskeletal Market Development here at Fujifilm SonoSite. I'm pleased to announce the arrival of the new SonoSite PX ultrasound system featuring the new 19 MHz linear array transducer. The format of the webinar is a quick high-level overview of common sports ultrasound applications with scanning demonstrations, immediately followed by a live Q&A session featuring the ultrasound scan-along. In an effort to keep a clean recording for the presentation, please hold your questions to the end of the presentation and have them ready for the live Q&A session with Dr. Tarek Awan. Tarek Awan, DO, is a board-certified family medicine and sports medicine physician. Dr. Awan is highly experienced in providing non-operative orthopedic care ranging from recreational to professional athletes. Clinically, he treats multiple musculoskeletal conditions and sports injuries of the extremities and has a particular interest in chronic tendon disorders, osteoarthritis, musculoskeletal ultrasound for interventional procedures, and the use of cell-based therapies. He has previous team physician experience with the University of Michigan Athletics and the NHL's Detroit Red Wings. As a part of his duties with Advent Health Medical Group, he serves as the team physician for the NBA's Orlando Magic. Welcome, Dr. Awan. I will turn it over to you.
Thank you, Daniel, for that introduction. It's great to be here with everyone as we talk about practical sports ultrasound and how to incorporate sports ultrasound into your practice. So this is the agenda we're going to go over. So those couple of the topics we're going to review are incorporating sports ultrasound into your practice, some of the advantages and disadvantages of ultrasound, the sports application of ultrasound and routine scans with demonstration. And then we'll also have some times for questions and answers with a live ultrasound demonstration. So please type your questions in the chat portal or hold them until the end. We'll have plenty of time for Q&A at the end of the presentation. So sports ultrasound, there are numerous advantages to ultrasound in general. The soft tissue resolution is quite remarkable. And for certain structures, the resolution is actually better than MRI, especially for looking at superficial tendons. You also have the advantage of neurovascular visualization, which adds another layer of safety when you're doing procedures. There's no radiation. You have real-time image. It's cost-effective compared to some of the other modalities. And then the other nice thing about ultrasound is you actually have the contralateral side for comparison. So if you're scanning a structure such as the shoulder and the elbow and you're not sure it's pathology, you can go and scan the other side for comparison. A lot of these units are small, so they're portable. You can take them with you to various clinics or to the sidelines. And another nice feature of ultrasound is the ability to do dynamic maneuvers. So you can use this to help enhance your diagnosis and further evaluation of structures to see how they respond to stress or dynamic maneuver. So we have here is evaluation of the rotator cuff and long axis plane. So you can see here, this is the bony acoustic landmark of the proximal humerus. Here's the supraspinatus tendon and long axis. You have the edge of the acromion right here. So when the patient abducts her shoulders, we can see how the supraspinatus clears the acromion here. So this is a dynamic maneuver for impingement. So despite the numerous advantages of sports ultrasound, there are some disadvantages. Ultrasound is one of those modalities where it's very operator dependent. There's also a lot of variability in the quality of the machines. Newer machines are much better in terms of soft tissue resolution. The technology of some of the machines have really improved over the last many years. Now, the other issue with ultrasound is for deeper structures and body habitus may be difficult to see. So while ultrasound is an excellent modality for superficial structures and tendons, there are limitations for looking intra-articular, so looking in joints, whether it's shoulder, hip, or knee. There are limitations in deeper structures. And with ultrasound, you're limited by bone as well. You can't penetrate through bone. So the other beauty of ultrasound that lends itself to sports practice is being able to do office-based procedures. So when you're planning to do procedures, an ultrasound setup is very important, because if you're going to try to do this efficiently, doing procedures while you're seeing patients in the clinical setting, having a system So you could do things in an efficient manner. It can really make the day go smoother. So when you're setting up procedures, you want to make sure you have good clinical support and help. You want to pay attention to ergonomics. You want to make sure that your patient and the machine are in front of you so you don't have to look over your shoulder. You want to optimize the settings on the ultrasound machine. When you're doing procedures, you're going to scan with your non-dominant hand and then your dominant hand to do the procedure. And I always recommend having an assistant in there with you, because if you're doing things sterile and whatnot, having someone to help with any patient-related issues or adjusting settings on the machines, I just think it's a good idea for patient setup and flow to have someone in there with you. So here's some slides that show the example of the soft tissue resolution of ultrasound. So whether you're looking at adipose, muscle, tendon, ligaments, bursa, nerves, capsule, or cartilage, the soft tissue resolution is really quite remarkable. If you look here in the upper left-hand portion, we have the distal portion of the patellar tendon. So this is proximal, this is distal, this bony acoustic landmark is a tibial tuberosity. You could see here this nice hyperechoic fibular structure of the distal patellar tendon. And contrast what you see, how a tendon looks like, to the echo signature of muscle. So muscles is going to be relatively hypoechoic with hyperechoic septation from the epimysium of the muscle. So this here is the gastroc and soleus junction here. And we have a ligament here. This is actually the medial elbow, proximal, distal. This is the ulnotrochlear joint, and this is the anterior band of the ulnar collateral ligament. So this is the proximal portion, this is the distal portion, this is the insertion on the sublime tubercle here, and you have the ulnohumeral joint here. So again, the soft tissue resolution of looking at some of these structures is quite remarkable. And then over here, we have actually, this is a sagittal view or a long axis view of the radiocapitellar joint. So again, this is proximal, this is distal. You can make out the characteristic bony acoustic landmark here of the radial head. Here's the capitellum. And notice this hypoechoic stripe here, this is actually the articular cartilage. So again, you can make out all these structures based on their echo signature with ultrasound. So this type of resolution and image quality is quite remarkable. So this is an example here of a triceps tendon. So not only can you visualize tendinosis, but with some features of these ultrasound machines, such as Doppler activity, you can also visualize hyperemia. So this is probe positioning for looking at the triceps tendon from proximal to distal. This is the corresponding ultrasound. So this is proximal, this is distal. So you can make out the tendon here. You can see how thickened and swollen it is. And this is actually the olecranon fossa, this little valley. So this is a long axis view of the triceps tendon. And coming here with the Doppler feature, you could see when we put the Doppler on, you can see the increased hyperemia here in the tendon. There's also calcification here. So you can see there's some sort of intra-tendinous calcification or in the superior aspect of the tendon. And one thing of calcification, sometimes they'll give posterior acoustic shadowing. So you can see here, this isn't a defect or a tear in the tendon, but this is actually posterior acoustic shadowing from this calcium here, because the ultrasound beam aren't penetrating through this almost like bone structure that's here in the superficial portion of the tendon. So again, you know, the ultrasound, you're able to see all these nuances, whether it's Doppler activity, the impact of calcification, the thickening and swelling of the tendon. So there's a lot of information you can glean. So the other nice aspect of ultrasound that we touched on earlier is the dynamic nature of it. If you're looking at a structure such as the ulnar collateral ligament in the medial elbow, you can put stress and you can see what happens to the joint. So this is a case of a 16-year-old right-hand dominant pitcher that was having medial elbow pain. He had typical exam findings of the ulnar collateral ligament with stressing and milking maneuver. And you look here, this is the MRI. So here, this is a coronal view of the MRI, and you can make out here the anterior band of the ulnar collateral ligament. So the ligament is intact. And this is the corresponding ultrasound with stress. So again, proximal, distal, this is the medial epicondyle, this is the ulnohumeral joint here, and this structure here is the anterior band of the ulnar collateral ligament. So this is a coronal view attaching on the sublime tubercle. Look here at the joint space here. So with the ultrasound machine, we could actually use calipers and measure the space. This is the contralateral side. So again, the nice thing about ultrasound, you have a normal comparison on the opposite side, so you can quickly scan the opposite side, put the images side by side, and this is the left elbow or the contralateral side. And you can see the difference in the, again, this is proximal, this is distal. Here's the anterior band of the undercollateral ligament. This is the medial epicondyle. This is the trochlea and the humerus here. And again, this is the ulnar humeral joint. So look at the distance here between the ulna and the humerus versus the distance here. So again, you have the opposite side as your normal control. So using the contralateral side and also stress maneuvers can help with this diagnosis. So the other thing that ultrasound is being increasingly used for, especially when you're in an area such as the sidelines or where you don't have immediate access to x-ray, is looking at fractures. So you can see the cortex and periosteum very nicely because of the soft tissue resolution is phenomenal with ultrasound. So this is an example of a wrist forearm buckle fracture. There's a pediatric fracture. So this is a 9-year-old baseball player that fell while running the bases, and he had extreme tenderness of the dorsal aspect of the wrist. So this is, again, proximal. This is distal. You can make out the growth plate here. So again, you know, the image qualities and the resolution is second to none here. This is with the 15 megahertz probe. This is with the 19 megahertz probe. So if you see here along the cortex, you can see here there's a little break or disruption in the cortex that you see here. And again, on the 19 megahertz probe, you can see there's a little blister or a little disruption in the cortex. And this buckle fracture was confirmed with radiographs as well. So now we're going to get into the live scanning. We're going to start with the shoulder protocol. So the shoulder is one of those structures that, based on the guidelines and recommendations, you want to do a complete exam. So you're going to be, in our systematic approach to the shoulder, we're going to start with the biceps, go towards the subscapularis, look at the AC joint, the subacromial bursa, the supraspinatus, the infraspinatus, and the teres minor. So as I mentioned previously, the shoulder is one of those structures that you have to do a complete exam. Now for other structures, you can do a more focused exam, whether it's going to be the medial aspect, the lateral aspect, anterior or posterior. So you can be a little bit more focused and limited, but with the shoulder, recommendations are usually to do a complete exam. So now we're going to start our shoulder demonstration.
Thank you, Dr. Awan. Now we're going to move to the live sports ultrasound demonstration using the new SonoSite PX and the L15 linear transducer. We're going to start on the anterior shoulder, right at the biceps.
So this is going to be our home base area. So you can see the nice bright bony acoustic landmark of the proximal humerus. And this is going to be an axial image. So to the left of the screen is lateral, to the right of the screen is medial. And you can see even more medial, you can make out some of the coracoid. So there's the coracoid process. So right in the middle of the screen, we have the proximal biceps tendon, and it's in the characteristic bicipital groove. And just lateral to that, we have the greater tuberosity. So that's one bony acoustic landmark. In medial, the biceps tendon, we have the lesser tuberosity. So that's where the attachment of the subscapularis on the lesser tuberosity. So this is our home base. We have the nice bright bony acoustic landmark of the proximal humerus. And then we can evaluate the biceps tendon, and we can move from proximal to distal. You can follow the biceps tendon down. And there's the tendon of the pectoralis major coming right over the biceps tendon here. And you can go back proximally. And then after you've evaluated it in short axis, then you can rotate the probe 90 degrees and evaluate the biceps in long axis. And again, the biceps it doesn't go straight up and down, it angles and it slants. So you have to heel toe the probe. So the probe can be placed parallel to the length of the biceps tendon. You can see you get this nice fibular pattern here when you're able to heel toe. And then again, you can follow the biceps proximal and from proximal to distal towards the myotendinous junction. And so you're getting into the muscle belly there. So then you can go back to home base. And then once you've evaluated the biceps tendon, then while you're in this position, you can evaluate the subscapularis. And to do this, you'll need to do a dynamic maneuver to externally rotate the shoulder. And you can see the subscapularis point into view. Now, this is an axial cut or a long axis along the length of the, or parallel to the fibers of the subscapularis tendon. So you can make out here, these are the fibers of the tendon. And then once you have this position, you can also rotate perpendicularly 90 degrees. And this is equivalent to a sagittal image that we would see on MRI. Now, again, here, when you look at it in this view, in a view, you could see that there's the hyperechoic tendon, but there's also some interdigitation with muscles. So don't mistake this for pathology. So as you scan back and forth, you can make out some of the interdigitation between the tendon and the muscle. So again, this is going to be equivalent to looking at a sagittal image, or this is a short axis view of the subscapularis. So then once we've completed our evaluation of the subscapularis, then we can go up and look at the AC joint. So you can evaluate the capsule of the AC joint. You can evaluate for bony irregularities. You can also do some dynamic maneuvers to see if there's any instability of the AC joint. And then if you slide laterally to the edge of the acromion, this is where we'll get into the supraspinatus. So again, you can make out this is a coronal view or long axis of the supraspinatus. So again, we have the bony acoustic landmark of the edge of the acromion. We have the bony acoustic landmark of the proximal humerus. And then you can follow that laterally to the greater tuberosity. And then you can make out the enthesis of the rotator cuff. And then as you slide proximally, then you get into the articular portion. And if you go see just right that's the articular portion of the rotator cuff. And then we can do dynamic maneuvers for impingement. Now, if you go back to that lateral view in the rotator cuff, you can make out, see that potential space or that thin hypoechoic line just superficial to the rotator. So that's actually the bursa. So the bursa is a potential space. It's almost like the lining of the heart, where you have a visceral and parietal pleura. So if fluid gets into that space, that's when you'll see a little bit of bursitis or thickening of the bursa. So that thin line is the subacromial bursa. So when you're trying to do an injection, if you want to have the injection placed into the bursa, you have to actually place it right into that dark hypoechoic region. So then here you can do a dynamic maneuver by having the patient abduct their shoulder, and you're just looking to see how the rotator cuff clears the acromion. So you're looking for bunching of the bursa, and if it fully clears, and you can see how the rotator cuff there fully clears under the acromion. So once we've completed this, then we're going to do a more thorough evaluation of the rotator cuff. Place the patient's hand in a position. There's various names for this, whether it's the Middleton or Crasp position. But basically, with this position, you're moving the rotator cuff out from under the acromion, so it can be visualized. So again, the probe is going to be almost parallel to the long axis of the humor to visualize the rotator cuff and long axis. So this is a long axis or coronal view. So when you're in this position, you're going to slide the probe you want to go medial to get the most anterior aspect of the probe, which you use the biceps tendon as your landmark. So there's your biceps tendon. So and just go slightly lateral to that, and that's going to be where you're going to start. You want to make sure you evaluate that area, and then you can slide the probe laterally, and you'll get into the area where the supraspinatus and the infraspinatus start coming together. And you can see as the bony acoustic landmark starts to flatten right there, it doesn't have that characteristic parrot beak. That's usually the area where you could tell the infraspinatus is coming into view. Now we're going to go from long axis to short axis by rotating the probe 90 degrees. So this is a short axis view of the supraspinatus here. And again, we want to use our biceps tendon to make sure we evaluate as far medially as we can. So there's our biceps tendon, and we have this characteristic wagging wheel appearance of this is a short axis view of the supraspinatus. And then we want to follow this distally towards the greater tuberosity, so you can kind of see how the tendon will thin out as you get towards the enthesis, so that there you have the greater tuberosity. And then the greater tuberosity has multiple facets. So you can make out the superior facet and the middle facet. That's where the arrow is pointing to. So then once we've evaluated the rotator cuff in short axis and long axis of the supraspinatus. Again, that's analogous to a sagittal MRI. We're going to relax the patient. Then we're going to go to the posterior aspect of the shoulder, and then we're going to start off with a short axis view through the infraspinatus and teres minor muscles. So we're going to start on the posterior part of the shoulder. The probe is going to be almost parallel to the long axis of the humerus, or the proximal humerus. So we're going to look for this characteristic biconcave appearance. To the left of the screen is proximal, to the right is distal, and you can make out the bony acoustic landmark of the proximal humerus, the humeral head. And then you can see that biconcave appearance. So the more proximal muscle is going to be the infraspinatus right there, and the more distal muscle to the right of the screen is going to be the teres minor. And then as you slide towards the tuberosity, then you'll be able to make out the central tendons of each muscle, and you can follow those towards their insertion. And if you look at the proximal, there we have you're starting into the tendon of the infraspinatus, and then we can also, once we find that, then we can do the same, follow the muscle belly, and then the central tendon of the teres minor, and we can follow that towards its insertion on the tuberosity. And then so you can find these in short axis, and you can go back to the infraspinatus, and then you can find and then you can follow it towards the insertion. Then you can rotate the probe and interrogate the infraspinatus in the long axis.
So, Dr. Awan, do you find this to be a challenging view sometimes, where the infraspinatus tucks under the acromion?
Yes, definitely. That's why I think sometimes it's easier to find it when you're following it from the view we just looked in short axis. And also, too, when you're interrogating the supraspinatus and the sliding posteriorly, sometimes that's just an easier way to get to the infraspinatus. Sometimes you can try and find it, just find the glenohumeral joint. And then if you slide proximal and distal, then you'll find the central tendon as you slide up and down. So again, you see the infraspinatus muscle there. So we have our glenohumeral joint. So there you can make out some of it. So you can just use the posterior joint as a landmark. So there you can make out that central tendon, the infraspinatus. And then we could focus here. There's our glenohumeral joint. So to the left of the screen is medial. So that's the glenoid. To the right of the screen is the proximal humerus. And then you can make out, see that hypoechoic contour on, so that's the articular cartilage of the proximal humerus. And then you could see that you could make out the joint capsule, which is that hyperechoic band that goes from the humeral head to the glenoid. And you can follow that to the glenoid. So if you're doing a glenohumeral injection, you don't have to dive deep. And there you have that triangular structure, the posterior labrum. And then we can do some dynamic maneuvers here with external rotation, just to evaluate for any fluid or whatnot in the glenohumeral joint. So when you're doing this, sometimes you may see a vein dilate. So you want to make sure you're not mistaking that for a cyst, because you don't want to go sticking needles into a vein. And if you're sliding medially there, you can, that right there is the suprascapular nerve at the spinal glenoid notch. So that's an area where if someone has a paralabral cyst, they could potentially have suprascapular nerve involvement. Now, typically, if it's at this level, the spinal glenoid notch, the supraspinatus will be spared, and most of their weakness will be to the infraspinatus. So I think that concludes our examination of the shoulder.
So now that we went over the demonstration of the shoulder and elbow, we're going to look at the posterior thigh and knee, starting with the proximal hamstring and working our way distally. And then we'll also briefly look at some peripheral nerves that we can encounter in this region. So this is a schematic of the hamstring. Sometimes the hamstring anatomy can be complicated. So if you look here on this diagram of the ischial tuberosity, so laterally we have the long head of the biceps, we have the biceps femoris, and then we have the semitendinosus muscle, and they share this conjoined tendon. And then you have the muscle of the semimembranosus, and then you have the membrane, the tendon of the semimembranosus. So when you're proximal, you don't really have muscle belly of the semimembranosus. Most of the muscle belly is the semitendinosus and the biceps femoris. And then you'll have the conjoined tendon, and you'll have the membrane of the semimembranosus. You don't start seeing the semimembranosus muscle unless you're more distal. So we can see this here on ultrasound. So this is at the level of the gluteal crease. This is an axial or short axis view. And this is image here is corresponding to this probe position. So it's right at the level of the gluteal crease. This is lateral, this is medial. So right here with this honeycomb structure here is the sciatic nerve. We have the biceps femoris muscle, which is here. We have the semitendinosus muscle here. Again, you can see it's more muscular here, whereas the semimembranosus doesn't come until it's distal. This structure here, this membrane is actually the membrane of the semimembranosus, and this is the tendon of the semimembranosus. So we have the muscle of the semi-T and the tendon of the semimembranosus here. And then as we start to scan distal, so again, if we slide a little medially, again, we have the muscle, the muscle of the semi-T, the tendon of the semimembranosus. And as we start to slide distally, then we'll start seeing the semimembranosus come into view. So this is a hamstring case. This was a track athlete that continued to have a persistent pain after a hamstring injury and just wasn't progressing or coming along. And the area was near the mid portion of the hamstring. So we had radiographs here and really didn't see any abnormalities on the radiographs. And then here's the corresponding ultrasound. So we could see a little bit of signal here at the myotendinous junction. But look what we have here on ultrasound. So again, one of the nice things about ultrasound, you could do side-to-side comparison. So this was the affected side. This was the unaffected side, or the opposite side of the control. So again, remember we're at this region of the gluteal crease. We have the sciatic nerve here. Here's the conjoined tendon, the biceps femoris, and the semi-T. And then again, you can see here, this is actually early heterotopic ossification or heterotopic calcification that wasn't present on, we weren't able to visualize it on the MRI or the X-rays. It's actually impinging on the sciatic nerve. So again, this is going to be lateral. This is going to be medial. This is side-to-side comparison. We have the biceps femoris, the semitendinosus. We have the membrane of the semimembranosus, the sciatic nerve, and then the conjoined tendon is up here. So we can rotate the probe on long axis and look at it along a long axis view of the sciatic nerve. So you can see the sciatic nerve is here, and you have this early heterotopic ossification actually impinging on the sciatic nerve here. So again, the soft tissue resolution and the ability to pick up this type of early heterotopic ossification that wasn't visualized on either MRI or X-ray. So now we're going to get into the posterior thigh and knee demonstration. I think patient modesty is going to be important. So anytime you can cover an area, you want to try and cover the areas you're not going to be scanning as best as you can. And the patients are going to be a little bit anxious, they're in pain, and then they're having a test. So anything that can make the patient feel a little bit more comfortable will go a long way. Also, another thing to be cognizant of is of the scanner and the patient of opposite sex. It may be worthwhile to have a patient advocate in the room as well, especially when you're scanning your sensitive areas. So when you start with the proximal hamstring, I think a good area to start is in the area near the gluteal crease, and then you'll often hear this term, the Mercedes-Benz sign. Again, you have this almost looks like a Mercedes-Benz symbol here, so I think this is a good starting point. So if you slide the probe laterally, slightly, there you go. You can see that structure. So this is going to be the Mercedes-Benz sign. So you can almost make it out. So that structure there in the center of the screen is going to be the sciatic nerve right there. So the left side of the screen is lateral, to the right side of the screen is medial. So we have the sciatic nerve. To the left is the muscle, the biceps femoris. So that's going to be the lateral muscle there. You have the sciatic nerve, and then superficial to the sciatic nerve, almost above it, you make that hyperechoic structure. That's actually going to be the conjoined tendon of the biceps femoris and the semitendinosus. And then if you slide medially, you have the muscle of the semi-T. So that's the semi-T muscle. And then the membrane that's inferior or deep to the semi-T muscle, that's actually the membrane of the semimembranosus. And then that structure right there, the arrow, is actually the tendon of the semimembranosus. So at this point, the semimembranosus is more membranous or tendon here. You really don't make out any of the muscle belly. So all the muscle belly you see here is the semitendinosus. So if you go immediately, slide the probe medially, that's all membrane of the semimembranosus. And then that's all muscle belly
of the semi-T. And then as you start to scan distally, then you make out the muscle belly of the semimembranosus on the medial aspect. So if you focus to the medial aspect of the semitendinosus muscle, we can go a little bit more medial there to get the, and then if we scan distally, that's when then we'll start to make out the muscle belly of the semimembranosus. Right there. It starts off as just right there. There's the muscle belly of the semimembranosus there. So again, this is a good start. So let's go back to our home base of the Mercedes-Benz sign. So again, this is a good area to start. You have the conjoined tendon. You have the semimembranosus medially tendon, and that's all membrane. And then there's the semitendinosus muscle. Again, the muscle belly of the semimembranosus won't come in until you go more distal. And then you can make out the muscle belly there. And then we have the lateral muscle is going to be the biceps femoris. So again, it's really easy to get confused with the anatomy. So use your home base of that Mercedes-Benz to start and orient yourself, and then you can follow the structures proximally and distally. And if you go back to the conjoined tendon here, you can follow it proximally till it inserts on the ischial tuberosity. Now the interesting thing of the tendon is if you go distally, so you want to pay attention. So go back distally to the Mercedes-Benz starting point. So you have the conjoined tendon and then the tendon of the semimembranosus, right? So the conjoined tendon here is a little bit more lateral. The semimembranosus is a little bit more medial. Now, as you move proximally towards the ischial tuberosity, now some patients, you actually make them out closer to the tuberosity, but they're actually going to crisscross. So if you look here, let's see if we can, as we move proximally, they'll crisscross and the semimembranosus will be more lateral. And then the conjoined tendon is going to be more medial when it attaches on the ischial tuberosity. So again, we have the bony acoustic landmark of the ischial tuberosity there. And then you have the hyperechoic conjoined tendon and semimembranosus tendons attaching on that ischial tuberosity. So again, that's going to be the hamstring tendon and short axis. And then we can rotate the probe. So again, before that, actually, let's go back. And if you just slide back and forth and just try to pay attention to the orientation between the conjoined tendon and the semimembranosus tendon as they attach. You can see here the semimembranosus is starting to go medially to the tendon. So it's gonna attach more laterally on the ischial tuberosity. So they actually crisscross as you go proximally. So again, you have the bright hyperechoic tendon, hamstring tendon, and short axis. And then we can rotate the probe 90 degrees and we can evaluate the hamstring tendon and long axis. And again, you have the bony acoustic landmark of the ischial tuberosity, and you can see the nice hyperechoic fibular structure of the hamstring tendon and long axis. And the same, you can follow you can evaluate the sciatic, and you can see the nice filamentous structure of the nerve. And you can follow this approximately and distally. And you can follow it distally till it branches. You're going to follow the nerve distally and you look at branches, best to look at it axis. So if you want to look at the branching of the nerves into the perineal and tibial branch, we can actually follow the sciatic nerve down. So we'll go ahead and follow it. And the nerves in the center of the screen right there. There we go. You can see if you windshield, now you with nerves, you want to windshield, once you see it, you want to windshield back and forth quickly, because when you move quickly, you actually see it better once you get to the area of branching. So you can make out to the lateral portion of the screen is going to be the perineal nerve, and that's the tibial nerve to the right of it, or the medial aspect of the screen. So the perineal nerve is going to go superficial. But if you scan back and forth quickly, you can see just going back and forth, you can really see that nicely how they're branching off. So kind of doing this quick scan back and forth sometimes can be helpful in visualizing these nerves. So again, you can follow each nerve distally. We can keep follow. Let's focus on the perineal nerve and follow that.
All right, I'm going to follow it. So here it is here. I'm going to bring my depth up more shallow.
So it's going to be in the posterior lateral aspect of the knee in this area, medial to the biceps femoris, and then it'll kind of loop around. You can make out if you follow it, then it's going to you're going to be in the region of the fibular head.
So here, now you're actually near the femoral condyle. So you can make out the articular cartilage of the femoral condyle. So you have the peroneal nerve, the femoral condyle, and the biceps femoris muscle. And then if you keep following it distally, then you're gonna reach the area. And there's actually the lateral head of the gastroc to the right. And then if you keep following it, the nerve distally, and eventually reach the area where it crosses the fibular head, and you can make out there the proximal portion of the fibular head there. So you can see that very nicely. And then we can follow it back proximally till see nicely. You can go back to where it connects with the tibial nerve to form the sciatic proper. So then we go back to home base. We can follow the so there again you have the tibial nerve to the right or medial, and the peroneal nerve to the left or lateral. So very nice. You see them branching. So we go follow that proximally, and we go back to our home base, or the Mercedes-Benz sign.
Yeah, I noticed it dove on me again. So here it is down here deep.
Oh, I'm sorry, you're going distally. So we're following it distally.
So now I'm back up.
Yep.
Going for Mercedes.
Now back to the sciatic nerve. Now we can also follow the muscle bellies as well. So we go once again, start at the home base, and then we focus on the biceps femoris, which is going to be lateral.
Okay.
We follow it distally as well, the biceps femoris muscle.
So this guy here.
Yep. You can keep an eye here because there you can make out the short head and the long head. So if you keep following the biceps femoris.
All of this guy here.
So that's the superficial portion is going to be the long head, and then that almost rectangular portion is going to be the short head as you go right in that area.
And then I see the bifurcation happen here, right as we notice the long and short head.
Yep. There's the long and short head of the biceps femoris. Yep. And then you can make out the bifurcation.
There's our nerve. Boom, it splits right there. Really nice.
Now, typically when I'm looking at the tendons, the hamstring tendons, or I usually like to either start proximal in the gluteal crease where we just looked at, or behind the knee. Sometimes it could be tough to get oriented if you're starting in the middle of the thigh. So I usually like to start in the posterior knee or at the proximal portion at the Mercedes-Benz area. So again, we make out there's a pulsating vessel. And to the left of the screen is lateral. We can make out the lateral femoral condyle because you can see the characteristic contour and then the hypoechoic stripe of the articular cartilage. So we have the lateral femoral condyle, and then we have the medial femoral condyle to the right of the screen. So again, you have the medial femoral condyle, and then we have the nice pulsating artery. So this is going to be where the neurovascular structures are in the tibial nerve in this region, the posterior knee. So you can make out the artery and the tibial nerve just next to it. So again, you see the vein with compression. So if Daniel lightens up the pressure there, you can see the vein. So again, you have the tibial nerve, the vein, and the artery in the posterior knee. So we go near the area of the medial femoral condyle. We actually want to find our semimembranosus tendon. So we're going to look for our semimembranosus tendon and our medial gastroc, because those are going to be landmarks for looking at Baker cysts. So you can see the muscle belly there. It looks like the medial head of the gastroc. So the medial head of the gastroc has a tendon, and you can make out that hyperechoic tendon right there. And then you see what Daniel did with the anisotropy. So there was a structure just right of that. You see how so that's a nice little tool to use to find the semimembranosus tendon, is using anisotropy. So you look there, so just by angling of the probe. So there's the hyperechoic stripe of the semimembranosus tendon. And then superficial to it is actually the tendon of the semi-T, or the semitendinosus is superficial, just to a little bit more medial to that. So the medial is going to be the on the medial part. So you have the semi-T, and then you have the semimembranosus tendon.
Now, the semimembranosus tendon doesn't go to the pes, so it attaches to the posterior tibia. So if we rotate the probe and long axis, we're going to have a nice landmark here with the bony acoustic landmark of the femoral condyle. And then we can make out the attachment. And there we have, so again, we have to the left of the screen is proximal, to the right is distal. So you have the contour of the bony acoustic landmark of the medial femoral condyle. That hypoechoic stripe is actually the articular cartilage. And then that hyperechoic fibular structure that goes over the joint again. So you have the femoral condyle, and then you have the tibia to the right of the screen. And then the structure in between is actually the posterior horn, the medial meniscus. So you have all those so those are all nice landmarks. And then the hyperechoic fibular structure that attaches in the posterior tibia is going to be the semimembranosus tendon. So again, you can use your bony acoustic landmarks to help you find the semimembranosus tendon long axis, because you'll have both the femur and tibia in view in the posterior horn, the medial meniscus, so you can follow it distally to its insertion. You can see that nicely, the insertion there of the semimembranosus tendon. And then we go back to short axis at the Baker's cyst area. So again, the Baker's cyst is, by definition, Baker's cyst has to originate from this region in between the semimembranosus tendon and the medial head of the gastroc. So this is going to be the area where you look for Baker's cyst. And we can follow these tendons proximally as well. So if you follow the semitendinosus tendon proximally, you can see that it's kind of opposite as you were in the gluteal or hamstring region. It's more of a tendon strip of the semitendinosus and more muscle of the semimembranosus. And if you start getting more proximal, that's when you get into the muscle of the semi-T. So again, you see there. So you go slide from proximal to distal. Let's go distal towards the tendon. Go distal, there you go. So there's the tendon, and then the muscle actually is semimembranosus. And then as you start to go proximal, that's when you start getting into the muscle of the semi-T. It's a very nice image there. And so we looked at the semi-T and the semimembranosus. If we move laterally now, so there we have the semimembranosus on the femoral condyle. If we move laterally now, we can, the other structure we're looking at is the biceps femoris. So we look at the biceps femoris attachment here on the fibular head. Now, one way you can look at it is actually you can start on the lateral knee, find the joint line. So let's go to the lateral knee. So you can look at it, so this is a way of looking at it from the side. So this is using bony acoustic landmarks. So if you find the lateral knee, so you can palpate the fibular head. So again, that's a nice picture. So to the left of the screen is proximal, to the right of the screen is distal. You can make out the fibular head to the right of the screen. And then you have you can make out a portion of the tibia and a portion of the fibula to the more proximal to the right. And that nice hyperechoic fibula. So that's a very nice view of the biceps femoris.
That concludes our webinar. Now we'll open up the floor for a Q&A session.
Yeah, I'm going to start with some chat questions. Are there any positional changes you utilized for larger habitus patients? And I think you might be on a different mic, if you could be a little louder somehow.
Okay, let me check on that real quick.
So Dr. Juan, can you speak to that? Are there positional changes?
Oh, based on body habitus?
Yes.
I mean, I think that on the area you're scanning, because sometimes you may have to do some things with the, either using a different frequency probe and whatnot. But I think a lot of it's going to depend on the body area you're looking at. I think the best thing to do is sometimes with larger habitus, you can't really palpate. So that's when you really should focus on using your bony acoustic landmarks.
Right. Okay, another question came in the chat, and I'm not sure if I'm going to pronounce this right. Is everyone getting an echo? There's an echo now, Daniel, but I will try to ask this. Oh, it's gone. So the question is, could you please capture an image of the popliteus muscle or techniques for identifying it?
Yes, absolutely. Can you still hear me okay? And
Much
Dr.
better.
Awan, when we were scanning, Dr. Awan, you if you could have been here, I think you would have slapped my hand for palpating while I was scanning. So this would be a good time to go through those bony acoustic landmarks for the larger body habitus, so that we're not scanning relied on what we're palpating, right?
Correct. I think the question was to look at the popliteus muscle.
Okay, let's give it a shot.
So I think just by knowing, the landmarks, it's usually going to sit on the posterior part of the tibia. So if you find the tendon on the latter part of the knee and try to follow it over, and then when your probe is going to be almost perpendicular to the long axis of the tibia. So a lot of times you can see that muscle that you're going to see on the posterior tibia. A lot of times you can use the bony landmark as well.
So here I've got, at the very least, a medial femoral condyle.
Mm-hmm. So you're on the femur.
And I can tell that because of all the cartilage. Let me try to get this thing done a little bit more. Where would you have me go from here, Dr. Wan? I'm gonna head down to the tibia, correct?
Why don't you start? Yeah, it's going to sit on the posterior part of the tibia. Why don't you start at the lateral part of the knee, find the tendon, and try to work your way back?
Okay, I'm gonna roll the leg out just a bit and go in a coronal plane, trying not to palpate like I normally would, right? That's the challenge today. Looking for that popliteus groove. I'm gonna bring my depth up just a touch. So I see a tendon in that groove. And at that point, I'm just gonna turn and oblique the transducer.
And rotate. Yeah, so you may lose it because it kind of courses obliquely, but if you turn on it, find the tendon and long axis now, and just try and follow it to the posterior knee.
Yeah, right there, here we go.
And then once you're on the posterior part of the tibia, you'll see bone.
Yeah, that's what I traced. Let me get the arrow up here.
And it courses obliquely as well.
There we go. So going back to the groove, here's our groove. And then here's our popliteus in the groove, and it's going to jump up and posteriorly.
Yeah, it's going to wrap up because it rotates the popliteus rotates the tibia on the femur. So it's going to be the deeper muscle. So it's going to be deep to the gastroc, and it's going to sit on the posterior tibia.
So I'm following this guy here, correct?
Go more towards the mid portion of the knee. It's going to be deeper on the bone. I think he's right there.
Great. Yeah. There, I just added a little bit of depth, and I'm looking at that muscle.
That's right on the tibia, the deeper one right there. Yep.
That is not a muscle I look at very commonly, so I'm glad I've got you here to coach. I look at the tendon all the time when I'm evaluating LCL. It's a good landmark for me, but it is not one that I trace out in its entirety very often, or have.
Yep, but that's it right there. Yep.
Excellent question. A couple more curveballs like that, and I think we'll have a awesome file.
I have another question here. In the case of the hamstring injury, how do you explain that the heterotopic ossification was picked up on MR but not on ultrasound?
It's actually the other way around. It was
around, right?
On the MRI. It was picked
up.
Was
not picked up on MR, but was picked up on ultrasound. I'm sorry.
And I think that has to go to the field of view and the soft tissue resolution. So for the soft tissue resolution is actually higher with ultrasound, and with the MRI, it's such a big field of view. So if it's something early and small, given those two, that's probably one of the reasons why it wasn't picked up on MRI.
All right. Okay, we have another question here. Any tips for separating the biceps femoral from the LCL on ultrasound? It seems like the biceps femoral gets in the way of the LCL sometimes.
So they actually will form a V. So the front portion of the V is going to be the, so if you're going to the lateral knee, so they'll almost form like a V. So the front part of the V is going to be the, so you can start by finding it, like if you're on the lateral part of the knee. So that's where, so Daniel now is on the biceps femoris. And then the LCL is a little bit more anterior. So if you start at the lateral joint line and you work your way down and you go to the fibular head, you know, the first structure you'll encounter is the LCL, and then if you windshield wash posteriorly, then you can get into the biceps femoris. So if you kind of put your fingers up like a V, the front portion will be the LCL and the back portion will be the biceps femoris.
Okay.
How's that for a
Yes.
graphic there? So I'm going to put fibula in the shot there, and if I'm aiming anteriorly, we're on LCL, and I can follow that to the epicondyle of the femur over the popliteus there. So I'm going to go back to fibula. Now I'm going to plant the distal portion of the probe and fan the probe.
And there's your V.
Proximally now.
And there you got a nice picture of the biceps femoris.
There it is superficially. And I'll point that out with the arrow and try not to get my big old head in the way of what we're scanning, but here we go.
Great.
Excellent question.
Excellent question. And we have one more. Any tips on evaluating for ACL injuries or using translational distance between femoral and tibial condyles?
So that, you know, the translational distance you can use stress radiographs are probably better for that. Now, one of the limitations with ultrasound is, you know, for visualizing intra-articular structures. Now you can see the posterior part of the ACL in the back of the knee. So if you look between the two condyles, it sits near the lateral condyle. So if you go back to that view, and if you get both condyles into picture, and then right off the lateral condyle, you can see a portion of the ACL. So that's the most proximal portion off the lateral. So if you look, so that's sort of, Daniel's got the arrow on it. So it's going to sit up kind of against the lateral condyle. The other place where you can see it is with the patient supine, and you hyperflex the knee, and you can catch some of the fibers very deep. If you look at the on the anterior part of the knee, yeah, right there. So those are some of the fibers of the ACL there. So you kind of just use the lateral condyle as your landmark, but it's the very, you know, it's right at the portion right, kind of at the notch. And then if you hyperflex the knee, you can actually see some portions anteriorly, very deep.
So I can actually change and flip our patient over, and we can look from the top part of the knee. We've got.
Remember, it angles from slightly medial to lateral. So you gotta have to angle your probe a little bit, but if you hyperflex the knee, and you'll see it's gonna, because you're not gonna be completely hitting it, you know, so there'll be a little there it is right there, and you'll hit a little anisotropy. So it's that little hypoechoic stripe with the hyperflex knee.
Great. And that person said thank you.
Excellent question again. Dr. Awan, I know you have another time commitment just a little past the hour, so we can turn you loose, but I don't mind for the group staying on and giving it my best in Dr. Awan's absence, but I do want to thank you for your time. And
I can stick around for a couple more minutes to see if there's anything.
Yep, if there are any questions, this is a great opportunity to do live scanning, being coached by an expert, and having a studio set up with a couple of cameras hitting where the transducer goes. So feel free to shoot the questions this way.
We just got one popped up. Any tips for co-reading anisotropy at the insertion of the supraspinatus at its watershed area?
So I think that just comes with comfort, because as you evaluate structures and as you move the probe, you know, for example, from proximal to distal, you're constantly going to be fine tuning and heel toeing the probe. Mm-hmm. So as you get towards, you know, you're gonna toe it and put a little bit more pressure. So these just little subtle movements like that, you can help, with the anisotropy. I don't know if Daniel can kind of just demonstrate. It's kind of typical too when we were looking at the biceps tendon, just rocking the probe, heel toeing, and then you can avoid some of that. So it's going to be these subtle movements, putting pressure more on one end of the probe versus the other, rocking, things of that. As you continue to scan, you'll get more comfortable with.
Right. Not seeing any other questions pop up. But person followed up with that. It says, as a fellow, I frequently have problems correcting a small articular surface at the insertion. It's always one small spot.
Yeah.
Yeah.
I find that anterior part of the supraspinatus, the coracohumeral ligament, the little space between that supraspinatus here, so supraspinatus, coracohumeral, leading edge of the supraspinatus, kind of, sometimes you'll see a little divide there, an anisotropic divide, and it'll mimic tendinosis sometimes. So that coracohumeral ligament is your border of the biceps. So here's our biceps, and then here's the coracohumeral ligament, and then here's your supraspinatus. And coracohumeral ligament fibers, some will come up on top, some will come under on the bottom, but that little wedge of anisotropy can really throw you off. So just be aware of the rotator cuff interval ligaments, and they can sure mimic cuff pathology the first couple of times before somebody points that out to you or you find it out the hard way.
And remember, the interval at the rotator interval is the intra-articular portion of the biceps. So one clue is once you get into the intra-articular portion, the bicipital groove is gone, so it won't be concave, it'll be round and convex. So that'll kind of let you know you're in the intra-articular portion. You'll lose that little, the little dip in the groove. So it'll be just completely round. So that's how you know you're in the intra-articular portion, and that's the area of the rotator interval. Right where you're at there.
Great. Okay. It looks like that might be it for questions. Oh, wait, one more question. When I scan the supraspinatus tendon and I see a tear, the MRI frequently shows extension into the infraspinatus.
I mean, it just, there's different types of tears in size and dimension. So, with ultrasound, sometimes it can be tough to differentiate because they almost, blend together. And you'll see that too on certain views on the MRI, like the sagittal images. So a lot of times you just, anatomically, they kind of overlap and blend together. So with, certain tears of certain sizes, they will extend posteriorly into the supraspinatus, with larger tears.
Okay. I'm not seeing any additional questions, so I think, Daniel, do you want to wrap it up, or?
Yeah, sure can. Again, thank you everybody for your time. Excellent talk, Dr. Awan, and scanning pearls and words of wisdom when it comes to troubleshooting things like an impinged nerve and the sciatic. That could be something that conventional imaging would miss every time. So showing a good soft tissue modality is great. Thank you, Laura, for running the chat portal. And if you have any questions about this webinar, our future webinars at sonosite.com on the SonoSite Learning Institute, which are free. You can actually log on and see those. We've done a number. Laura has the actual number, but we have 15 MSK webinars recorded, and we have 6 more slated through the summer, basically. And then if you have any questions about the equipment that was used, the SonoSite PX, and unfortunately we didn't get to the L19 transducer, very high resolution. A few of those webinars did capture that new L19 transducer in action. Like the lateral femoral cutaneous nerve webinar was really, really nice for the L19. That comes to mind. In the elbow, we did ulnar collateral ligament with the L19. If you have any questions about the equipment that you saw, my email address is it was on the screen, daniel.shelton@fujifilm.com. You can just email me directly, or I'm sure get my information through the host of this webinar, Andy, and he'd be happy to put you in touch with me as well. But we do thank you for your time. We know your time is valuable, so we're going to go ahead and cut you loose for the evening. But it was wonderful to have the opportunity to be in front of you guys during these tough times, and conferences are all getting canceled. And I would normally be there in the exhibit with you, learning with you and talking with you about cool ultrasound stuff, but we just have to do it a little different this year. So we appreciate you logging in these late hours and allowing us to put a message in front of you. And we look forward to seeing you later in the year. Thank you and have a great evening.